Welcome to my YouTube channel. In this video, I will talk about abdominal masses in the newborn. Most abdominal mass lesions in the newborn are benign lesions. Goal of the treatment is to recognize the abdominal mass that require urgent evaluation and treatment. First important type is the renal masses in the newborn. About 2/3 of the abdominal masses in the neonate are renal in origin. These may be unilateral or bilateral, solid or cystic. First important cystic renal mass in a neonate is due to hydronephrosis. It is typically unilateral and results from vesico-urethral reflux or obstruction at the uretero-pelvic junction. Second important cystic renal mass is multicystic dysplastic kidney. In this, numerous non-communicating cysts that vary in size with little to no normal tissue is identified, and this is usually unilateral. Third is autosomal recessive polycystic kidney disease. It is usually bilateral and presentation varies with the degree of hyperplasia of collecting tubules and may be detected in utero or later in the childhood. Now the solid renal masses. In this, renal vein thrombosis is an important cause. Typical presentation is one or more flank masses and hematuria, usually within first 3 days of life. Risk factors for renal vein thrombosis are maternal diabetes and dehydration. Ectopic kidney or horseshoe-shaped kidney are also an important cause of solid renal masses in a neonate. Another important solid renal mass is congenital mesoblastic nephroma. It is the most common renal neoplasm in the infants and usually present before 3 months of age as an asymptomatic abdominal mass, but may be associated with hematuria, hypertension, hypercalcemia, and even congestive heart failure. Fourth solid renal mass is Wilms tumor or nephroblastoma. It is the most common renal malignancy of the childhood, primarily occurs between the ages of 2 and 5 years, but it can develop in an infant. Most cases are sporadic, although hereditary forms do exist. In nephroblastoma, patient may be asymptomatic or present with abdominal pain and hypertension. Unilateral involvement is most common. Now, neonates with Weger, Dennis Trash, and Beckwith-Wiedemann syndrome are at increased risk for the development of Wilms tumor and require frequent screening. Now, in all these cases, depending on the size of the renal mass, some infants may develop feeding intolerance or respiratory distress in the setting of profound abdominal distension. Infants with renal masses should be monitored closely for hypertension, as most causes of hypertension in neonates are renal in origin. Now, in case of renal masses, evaluation should include ultrasound to distinguish cystic from solid lesion, serum testing for renal function evaluation. Infants with hydronephrosis may also require Whiting cystourethrogram to assess for comorbid vesico-urethral reflux. Now, second important type is hepatic masses. Hepatic masses in neonate are extraordinarily rare and can represent significant pathology. Because of vascular nature of the liver and relative immaturity of the hepatic capsule, rapidly enlarging or vascular lesions are prone to bleeding and thus can result in significant hemorrhage. Patients with palpable hepatic masses should undergo additional diagnostic testing with ultrasound, as well as serum testing for complete blood count, liver function test, coagulation studies, and alpha-fetoprotein. First important hepatic mass is congenital hemangioma. It is often detected prenatally. It is usually solitary lesion that mature by birth and may involute by age 2 years or persist for life. It may cause heart failure, thrombocytopenia, and anemia. Treatment options include digitalis, corticosteroid, embolization, hepatic artery ligation, or liver resection in severe cases. Second important hepatic mass is hepatic mesenchymal hematoma. It commonly have a cystic component and are characterized by fine internal septation without calcification. Third important hepatic mass is hepatic hemangioendothelioma. It is reliably diagnosed with MRI or contrast CT scan. In this, infant has usually normal alpha-fetoprotein levels. In this case, symptomatic lesion, for example Case-Beck-Merritt syndrome, are treated with interferon, systemic corticosteroid, vincristine or cyclophosphamide. Hepatic resection and liver transplantation are reserved for selective cases. Now, third important type of abdominal masses in a newborn is adrenal mass. Adrenal hemorrhage is an important cause of abdominal mass. It occurs as a result of birth trauma. Clinical manifestations depend on the degree of hemorrhage and include signs of anemia and rarely adrenal insufficiency, which include poor feeding, vomiting, diarrhea, obstipation, dehydration, irritability, hypoglycemia, uremia, and shock. Treatment is largely supportive and may include corticosteroid in the setting of adrenal insufficiency. Rarely surgical intervention for vessel ligation or adrenalectomy is warranted. Second important adrenal mass is neuroblastoma. It is the most common cause of neonatal tumors and it occurs most commonly in the adrenal gland. It can be distinguished from adrenal hemorrhage by ultrasound and is confirmed with urine homovanillic acid and vanillyl mandelic acid levels. Now, fourth type of abdominal masses in a newborn is pelvic masses. Ovarian cysts are important pelvic masses in newborn. These ovarian cysts can result from maternal hormonal stimulation in utero and are often diagnosed in fetal period, where the vast majority resolve prior to delivery. Now, simple ovarian cyst which persist is a frequent cause of a palpable abdominal mass in a female neonate. It presents as a relatively mobile, smooth-walled abdominal mass. It is not associated with cancer, and excision with preservation of any ovarian tissue is curative. Smaller lesion less than or equal to 5 cm may be followed with serial ultrasound until gone over the first year of life, as long as they continue to get smaller. Large or complex ovarian cysts may be at risk for torsion, so they should be treated surgically. Additional complications are rare but can include rupture with resultant hemoperitoneum or bowel obstruction. Now, last type is the gastrointestinal masses in the newborn. Now, important gastrointestinal masses are intestinal duplication and mesenteric cyst. Palpable abdominal masses that arise from GIT are very unusual in the newborn, and these tend to be cystic, smooth-walled, and mobile depending upon the size. Thanks for watching this video. Please like, share, comment, and subscribe to my YouTube channel.